Welcome, everyone. Thank you for being here with us for the next edition of our webinar series. And tonight we've got a very interesting presentation on Lyso-Gb3 with Dr. Uma Ramaswamy, and she is in London, so it's a little bit later for her tonight. And as usual, and thank you, Dr. Ramaswamy, and as usual, I'll introduce you to Casey, and Casey will introduce you to Dr. Ramaswamy, and then she'll tell you all about Lyso-Gb3 in this particular article review. So Casey, as most of you know, is a genetic counselor, certified genetic counselor, and the senior program manager for education and community support with the National Fabry Disease Foundation. So Casey.
Great. Thanks, Jerry. We are glad today to be joined by Dr. Uma Ramaswamy for her presentation of an article that she wrote or is the lead author for, called The Use and Performance of Lyso-Gb3 for the Diagnosis and Monitoring of Fabry Disease, a Systemic Literature Review. Now, Dr. Ramaswamy is a consultant in the Inherited Metabolic Disorder Clinic and is the clinical lead for lysosomal storage disorders at the Royal Free Hospital and an honorary associate professor of genetics and genomics medicine at the University of College London. She was just telling us that she has a very large Fabry disease patient population, which is reaching 500. So we are so glad to have Dr. Ramaswamy here to share her breadth of experience. And without further ado, we'll turn it over.
Yeah, thank you so much, Cassie and Jerry, for inviting me. It's a absolute pleasure. And I was just telling Cassie, I apologize if my lighting is not great, but it is quite dark here and I don't have great lighting in my house. So those are my disclosures, but I've received no honoraria today and it's an absolute pleasure to be here. So I thought the first thing I would do is just start off with a few slides on what a biomarker is and what is the information we've had so far on Lyso-Gb3 before I talk about the publication we did. So this is a long definition from the NIH. As it shows, it's a characteristic that it is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological responses to a therapeutic intervention. That's the basic definition. But in fact, actually, categories of biomarkers, we can think about it as, is it diagnostic? So whether or not someone actually has the disease, whether it is prognostic, it provides information on the likely course of the disease and you can correlate with treatments, and also whether it's predictive. So this would be really good, particularly if you had, say, females with Fabry disease and whether a disease-causing variant is in fact going to cause disease, severe disease, or whether it's going to be mild. So I think that's called, it's predictive. Now, we don't have an answer to all of this currently for Fabry, but what we do have, I think, is something that's pretty good, and this is the compound. And the compound that is the biomarker for Fabry is called globotriacylsphingosine. Now, we're going to talk about one type of globotriacylsphingosine or GB3, and that is Lyso-Gb3. And this was identified as a molecule in 2007 by Professor Johannes Arts from the Netherlands. And basically what this molecule is it's got two parts to it. It's got a part that is attracted to water on this side. It's got a part that's attracted to fats, oils, lipids, and it's positively charged. And at one end, you also have a group of sugar moieties or section, and this interacts with water and mixes well with water, and hence it's called hydrophilic. So the cationic amphiphile is just basically means it's got those two parts, one which is attracted to water and one which is attracted to fats and oils. So we do know in Fabry disease, the main substrate that accumulates, so it's down here, is globotriaosylceramide or GB3. And what Lyso-Gb3 is, it's the deacylated form, i.e., it is water soluble and therefore easier to measure. So you can still measure GB3, but Lyso-Gb3 is much easier to measure. Now, the other good thing is that Lyso-Gb3 accumulates more easily in plasma, and therefore we can measure it better than we used to be able to do with plasma GB3. So I wanted to start off with looking at some of the variants or the genetic variants. We don't call them mutations, we call them variants because of how they, whether they're disease causing or whether they are benign. And here on this graph, you can see that we've got Lyso-Gb3 on the y-axis, and you've got females as the first bar. This is on the x. And then you've got the males, and then we've got Fabry controls who do not have Fabry. This horizontal line here is just the median of the Lyso-Gb3 level for that particular cohort. And you can see those medians. And then each dot is in fact a patient. And Lyso-Gb3 in general, in males, will be 10 times higher than in females. And that's I'm not going to do the genetics of the females with Fabry that I'm sure you're very well aware of, but with the two X chromosomes, we have some patients can be quite severely affected due to X inactivation and some don't, but one of the X's will still be making some residual enzyme activity. I think that's probably the reason why males end up with much higher Lyso-Gb3. Now, at the bottom here, in pink, in blue, and in green, you've got these variants. Now, these are the variants that we call as variants of unknown significance or non-pathogenic variants. Now, we do have in our cohort some patients with these particular variants who have disease, but we think that that is probably due to some other epigenetic factors and not because they have a pathogenic variant. And these patients, in fact, will have quite often normal Lyso-Gb3. And then if you can look at the controls, all the controls are less than 1.8 nanograms per ml, which is the cutoff. So in fact, Lyso-Gb3 is really very good as a diagnostic test, particularly for the males with classic Fabry. So I'm not going to talk too much about treatment, but just that one slide showing that if you are a male with classic Fabry, and you start with a very high level of Lyso-Gb3, generally that Lyso-Gb3 will come down in the first 3 to 6 months. But in my personal experience, I've never actually seen it normalize. It comes down and then it stays low. Sometimes it can go high, and we'll talk about that in a minute. But you can see that that's what happens. Whereas if you look at patients with classic Fabry, although they may have significant organ involvement, their Lyso-Gb3 may not always be high. So it's really important for us to understand that females can have significant cardiac disease. They can have significant central nervous system involvement, for example, but their Lyso-Gb3 may not be high. So it's important we don't say, well, your Lyso is normal and therefore you do not have disease. So I think it's a really important message that I'd like to share today. What is the clinically meaningful level of change is really, I don't think we really know well currently, although I can say that if you have in our clinical guidelines, which I'm going to show you in a little while, we do give a percentage, but again, that's something that we've just discussed recently, and therefore we will need to evaluate that maybe in a few years' time. I also wanted to discuss the cardiac variant. Please ignore this busy slide. This is just for me to remind me that if you had the Lyso-Gb3 cutoff of 2.7 nanograms per ml, you remember I said normal is less than 1.8. So if you had a patient who had a Lyso-Gb3 value of 2.7 or more, that is typically what we see in the cardiac variants. And so even with the late onset cardiac variants, from a diagnostic perspective, you would expect that the Lyso-Gb3 will be elevated to that level. It's nowhere near what it would be for your classic patients, but that's what you would see. It's the same with also the Taiwanese cardiac variant and the late onset cardiac variant we see in the UK. But there are some other variants, for example, this particular one I've shown here, M296I, which in fact actually the Lyso-Gb3 will be normal, but they can present with cardiac disease. So in that scenario, I think you have to look at other biomarkers, which are disease-specific biomarkers, such as troponin, for example, or other renal biomarkers. One of the interesting things that we can use Lyso-Gb3 is to evaluate anti-drug antibodies. This is for patients who are on enzyme replacement therapy. And if you look at the classic male patient who has antibody positivity, the lyso might come down quite nicely. And then if, when you're measuring it again, you see that it's gone up significantly, then I think it's really important to consider testing for ADAs or anti-drug antibodies. However, if your antibody level is not great, it's low, it's weak, then you may not, the Lyso-Gb3 may not change significantly. And likewise for females, as I've said, and antibody negative patients, generally speaking, it kind of doesn't come down, but it stays the same and you don't see that sort of dramatic increase when you test it again. I just wanted to move on to looking at how plasma Lyso-Gb3 is measured. Jerry, is plasma lyso something that you routinely have done in the USA? So do all clinics do this all the time? I don't know, but so is that something that they do? You're on mute.
I'm trying to find my my mute button. So I don't know if it's routinely done across all clinics. I know that many clinics
Yeah.
test Lyso-Gb3. I have it tested at least once a month.
Okay, so that's quite frequent. We don't do that frequent. And I think once every 6 months or once a year, I mean, with the number of patients we have, we won't be able to do this as frequently, but it's great you can have it done. The reason I raise this is plasma Lyso-Gb3 requires your blood to be taken for it to be processed fairly quickly in the lab, and it needs to be transported. And if your lab is not next door to your clinic, then that becomes an issue, as it is for some of us. So I think one of the alternatives is to look at whether dried blood spots can be used. And there has always been this sort of reticence of whether the dried blood spots will give you an accurate result. So much to our surprise. So this is in fact my paper. So this was sort of a secondary outcome measure, if you like. The primary outcome in this particular study was looking at enzyme enhancement on a chaperone because the clinical trials had done it on HEX cells, and we wanted to see whether there was a true increase in plasma and leukocytes, which it did. But whilst we did that, we compared plasma lyso with dried blood spot Lyso-Gb3. And you can see from this graph that, the closer the circles are to this line, then the correlation is really good. And you can see the correlation here is actually pretty robust. And so we looked at the start of treatment, and we also looked at, I cannot remember what the study visit was, but in fact, both at baseline and at the study visit, these patients did really well in regards to plasma and Lyso-Gb3 on dried blood spot correlation. So I think personally, plasma lyso is not even, if you don't have the possibility, or if you're in a country where, sampling is difficult, then a dried blood spot Lyso-Gb3 would be perfectly fine. And of course, the dried blood spot has to be prepared properly and it has to be dried, but I'm sure the clinics will be aware of that. So what we decided is that, there was some anecdotal evidence and there was a little bit of information on lyso, but there wasn't anything where we could look at it systematically and say, truly, is lyso really most informative for diagnosis, What about ethnicity? What about age? What about women? And so we decided that we would do the systematic literature review. And this was a concept I created, and then those are my co-authors. So what did we do? So we used the methodology is called PRISMA. So it's a very long name. It's Preferred Reporting Items for Systematic Reviews and Meta-Analysis. So why we did this is actually a pretty good standardized framework, and it improves really the quality of all of the systematic reviews, and it's a good methodology to use if we're going to do this type of systematic literature review, and I'm going to call it SLR. So we looked at all of the studies from 2017 to 2022. That's the graph that's already in my manuscript, and I saw that Cassie's already published that on the website, which you can have a read. And then wherever we thought there were gaps, for example, I found nothing for ethnicity, we went right back to 2008 to see whether we could find any kind of literature that we could use. So we looked at, we included 83 studies, 71 were observational, and we had 12 clinical trials, including randomized and non-randomized trials. So what did we assess? The studies we looked at assessed patterns of Lyso-Gb3 testing, levels across subpopulations, so it was gender, phenotype, genetic variant, and we looked at anti-drug antibodies again, and its use in diagnosis, screening, particularly I was keen to look at newborns and also disease monitoring. We use the standard search templates, so we use Medline or PubMed, Embase, some key organization websites, and then hand searching and some grey literature. And even when we had articles that were not in English, we wanted to have a review to see whether there was something important that we could take away from those literatures. And using the PRISMA is good, and then we can also use other tools. These are all tools I won't expand too much today. And that's really to see whether the evidence we are gathering, whether it's robust and whether it's meaningful. So what were our key findings? So consistently in all of the publications, we found that Lyso-Gb3 was higher in males with Fabry disease, as I've already showed you in one of those reports. And look at the numbers we saw. So the mean lyso in males, classic males with Fabry disease, was close enough to 68 nanograms per ml compared to women where it was 6.3. So a very big, that's the tenfold difference that I mentioned previously. We also found that whether you had whether you were a male or a female, if you had the classic Fabry disease, not the late onset variants, then your Lyso-Gb3 was going to be higher. We also found, as I showed you before, that those patients who had the classic disease-associated variants, so you had a variant or a mutation that's going to cause loss of function and therefore very little residual enzyme activity, they had higher levels of lyso compared to those that were either benign or late onset variants. We also found, as I showed you already, consistently that in the presence of anti-drug antibodies, particularly in males on enzyme replacement therapy, Lyso-Gb3 was increased. And in my personal view, longitudinal Lyso-Gb3 levels therefore become really an important biomarker when you're assessing treatments. So when a patient has an infusion reaction, for example, we check anti-drug antibodies, we do serum tryptase and do other things. And I think at the same time, we should probably also be doing the biomarker to see whether there's a difference. There was very few studies to look at the differences by ethnicity or by race. And that we also found that the correlation between age was quite weak. I thought actually, in fact, lyso, because what it does is it increases smooth muscle proliferation, I thought it might be actually, there might be a correlation with age, but we actually didn't see that in this SLR. So what does that actually mean in a clinical setting? So I think from a diagnostic perspective, I think it's pretty good. And also what we found is that the laboratory methods, it's pretty robust across different laboratory methods. So, that's one of the reasons why I said that plasma and dried blood spot, I'm sure, can be can be used, whatever is actually useful. So if you can't get a plasma, dried blood spot is perfectly fine. There's still a real lower sensitivity for late onset females with Fabry disease, and I think we do need to look at this and maybe look at the lyso analogs, for example, which we can do in the urine, look at whether there are other things that we can find. But currently, the sensitivity is lower for late onset female patients. And we also found that if you had thickening of the heart muscle, so left ventricular hypertrophy, there was a correlation with an elevated lyso. And we found that with left ventricular mass index, but we also interestingly found this with the late gadolinium enhancement is something we see on cardiac MRI, and it's a reflection of myocardial fibrosis or scarring. So if you had later onset or end organ disease, or if you've got severe cardiac disease, Lyso-Gb3 will be elevated. But interestingly, we did not see that correlation with renal disease. And we know that Lyso-Gb3, despite being hydrophilic or water soluble, it's not really excreted easily in the urine. So we don't measure lyso in urine. We measure GB3, but not lyso. And we found this correlation was quite weak. There was some correlation with serum creatinine and increase in protein, but there was really nothing that we found with estimated GFR. So, as I said to you, it's very, very helpful. So if you had an elevated Lyso-Gb3, that patient, a male patient, does have Fabry, and I think it's great to have a biomarker that we can be certain in regards to diagnosis. It's very reproducible, and it's also the reproducibility between laboratories is good. However, as I've already said, non-classic or late onset patients and female patients, we need to measure Lyso-Gb3 in addition to looking at organ involvement more systematically, and not assuming that a low lyso means that a female patient or a late onset cardiac variant in a female patient does not have disease. So that's kind of one of the key messages I'd like from this talk. What's the potential impact? We could incorporate Lyso-Gb3 into diagnostics, but also monitoring, as I've already said. We could also probably think about individualizing treatment decisions, especially when you have so many Fabry therapies, which is it's a good thing to have, but how do you choose? And maybe we're not quite there yet, but I think maybe there is a possibility it could be used in that way. And I think as evidence evolves, it'll also likely play an expanded role in disease management pathways, particularly when you're looking at a broader multimodal biomarker strategy. So not just one biomarker, but maybe you can look at composite things. You can look, if you had somebody with severe cardiac disease, look at some of the cardiac biomarkers. Jerry, I do have 2 slides right at the very end, which I might actually show before we end it, so that you guys know what I mean by organ-specific biomarkers. I just had them just in case we need it.
Great.
I just wanted to show you this slide because I talked to you about, how do you monitor it. We developed these guidelines in 2025. These are revised guidelines. And here, look at this. So we're looking at efficacy. And we've said that Lyso-Gb3 should fall by about 20% after 12 months in classic males. Now, it's kind of based on experience rather than a huge amount of evidence, I would say. So this is something that we will have to monitor over time. And maybe in a few years' time, we will be in a better position to see whether this actually happens. These are the other indications, which I'm not going to talk about today. And finally, my last slide is looking at gaps in the literature. So we've talked about late onset patients and female patients. I think newborn screening is sort of for the next 10 years, newborn screening is what is going to really dictate how we manage lysosomal diseases, or in fact, metabolic diseases per se. And I think whilst Lyso-Gb3 is not sensitive enough for universal screening, once you start using it there have been studies showing the second tier testing, then I think we should really look at how we can use Lyso and thereon look at how we can monitor children as well. We have really very little information in this SLR because there isn't enough data on Lyso-Gb3. So children, again, another big unmet need. Research is sparse in ethnic and racial differences, and also looking at clinical outcomes. Currently, there is no real clear clinical correlation between clinical outcome and improvements in Lyso-Gb3. As I said, even in males, it comes down and then it just kind of plateaus but never comes to normal, but their clinical outcomes might be getting better. So I think, there's a huge amount of work we could do because this is quite a sensitive and quite a good biomarker, but I still think we have some unmet needs. And before I go to that, I just wanted to show you these two slides. So there are a number of potential renal biomarkers that you could use, as I've shown here, which I won't go through all of it, but some of you might have heard about cystatin, which we do for measuring glomerular filtration rate, and then there are a few others that you can perhaps use as a biomarker in addition to Lyso. In cardiac, probably it's even better. So we've got the cardiac MRI, which shows your T1 mapping, where you've got patients who have this lipid accumulation within the myocytes or the cells in the heart. That can be picked up even before you have thickening of the heart muscles. And in fact, cardiac MRI is a routine test we do now for our patients, particularly for the new patients. Not almost, all of them will have a cardiac MRI. We also know that this particular biomarker called troponin, or highly sensitive troponin, which is normally elevated when you have a patient with a heart attack. You go to your ER, the minute you say you've got chest pain, they think of a heart attack, that's what will be measured. In our Fabry patients, quite often this is elevated. But the difference between the elevation in Fabry patients, as I always tell when I'm contacted by somebody in ER saying, I've got a Fabry patient, got a really high troponin, but he has no evidence of a heart attack or myocardial infarction. In a patient with a heart attack, the troponin is dynamic, so actually it will increase. So they will measure it every 2 hours. But if you look at patients with Fabry disease, it will stay the same. So I think that's the main clue. So I will actually tell them, is your troponin dynamic? Is it going up? And if they say no, I say, well, it's due to Fabry disease. He hasn't had a heart attack, and therefore he can go home. So I think it's quite a good biomarker that you could use, and you can use that in combination with Lyso maybe, and we could correlate whether troponin comes down at the same time as Lyso and how it correlates. It might be a useful one to look at. We haven't looked at it, but it's something we can look at. So I just wanted to it's a quick tour de force about Lyso-Gb3. I hope I haven't rushed it, but I'm happy to take any questions, and it's been recorded and I'm sure you can listen to it, and that's my email, and if anyone wants to contact me with any questions, I'm more than happy to help if I can. Thank you.
Thanks very much, Dr. Ramaswamy. Great presentation. I think are there any questions out in the field yet?
Dr. Ramaswamy, I'm sorry if I missed this. I briefly disconnected. But have you all found any differences in how low Lyso-Gb3 drops in people with that are on chaperone therapy versus ERT, or has that been compared in people who have switched between therapies?
Yeah, there has been studies, hasn't there? There's been some studies showing patients who have been on a chaperone and then switched to enzyme replacement therapy, showing a better drop. But again, I think the studies were very small numbers. But what I would say to you, Jesse, it's important to measure lyso. And if you find that your Lyso-Gb3 is not going down sufficiently, i.e. that 20%, I mean, that I think that's a good guide. So if it's not going down in that first year, you probably should start thinking about, what is this treatment working for me or not? Now, I'm not saying you necessarily need to switch immediately, but I think that would be an indication for you to start thinking about. If you're on enzyme, think about your dose. If you're on a chaperone, then think about whether that is actually the appropriate one for you. And I think we'll have to look at it individually because at the moment, I don't think we have enough information to say this is one size fits all. We've never seen lyso come down completely to normal. So
Right.
I don't think, if your starting point was 80 and you've come down to 70, you've done brilliantly and
Yeah.
it's staying where it is. So I think, that's why it's important to take it within context, look at what the patient you've got in front of you, what are their symptoms, what is the organ involvement, and then take lyso in the context of that.
Right.
Yeah.
And the interest in Lyso-Gb3 came later, so I have no idea what my starting point was. Yeah. Great. Any other questions? If it's not about this paper, but what do you think about and I don't know if you were an author on the paper that found out that your Lyso-Gb3 levels come to some state of I won't say normal, stable as a child, like under 18 or something like that, and then stay that level throughout your lifetime unless you get treated. Does that sound right?
I'm not aware of that, but in my experience, if you had a classic patient with Fabry disease, your lyso will keep going up. It's not going to stay stable unless you have, a disease modifying treatment. So that is my experience. I've just seen there's a question in the chat. Shall I read it?
Yes, please do.
It says I had a couple of MRIs and I had a mild thickness of my heart and I had fibrosis on my heart biopsy, but they could not tell if it was Fabry. After changing treatment, my latest MRI is not showing the thickness anymore. My Lyso-GL3 is stable since the beginning. What varies is the Lyso-Gb? So what? I don't know what that last bit is. Is this how it should be? So I'm assuming that this patient, is it Nara?
Yeah.
So Nara. So you have a variant in the Fabry gene that they have identified as Fabry, and you have had thickening of the heart muscle, and you've also had fibrosis. Now, cardiac MRI in females, the reason why we always insist our females with Fabry have cardiac MRIs is because that fibrosis happens even before I see thickening of the heart muscle. And it's the back of the heart, it's the inferolateral wall. And that's not something I pick up on echo or ECG, for example. So that will happen quite early. Lyso-GL3 is not a good marker, as I've said to you already. So the next thing they can do for you is maybe look at another tissue to see whether there is inclusion. So, you've got the Fabry inclusions, that's the zebra bodies. So they might want to do a skin biopsy. I mean, skin biopsies they don't hurt very much. They're small, and maybe that's something they can do to see that's one thing they can do. And the other thing I will say to you is that the low native T1 that I talked to you about on cardiac MRI, as the heart muscle thickens, that will disappear. But you can ask them about that and see, did my cardiac MRI show low native T1? Because low native T1 and a little bit of scarring at the back of the heart is a good indication that you got early, well, it's not even early, it's Fabry cardiomyopathy. So that's something you need to discuss with your cardiologist. I wouldn't rely on a GL3 for your Lyso-GL3 or Lyso-Gb3, not for females, no. It could absolutely be normal.
Thank you.
Yeah.
Now, Dr. Ramaswamy, I have a question for you, or something that I guess took me a little while to figure out. Now, I remember maybe 10 years ago, maybe less, we were really excited about just GB3 or GL3. And we would measure it in the plasma or the blood, and we would also measure it in urine. But now that we're doing Lyso-Gb3, we're not measuring in urine anymore. Can you tell us a little bit more about why that is? Oh, and I'm sorry, you're on mute again.
As I said to you, GB3 analogs. So you can measure Lyso-Gb3 analogs. There's about 6 analogs, and Christian Orablay from Canada has done a lot of work on that. The problem with the urinary analogs, one, it's not reproducible, and you really need to have a very specific lab to measure these analogs. They're not easy to do. It also relies a little bit on, correcting for creatinine, correcting for, all of that becomes a bit of challenging. Lyso-Gb3, despite it being hydrophilic, is not excreted well. And therefore, really, that's why we don't measure it in urine. Whereas it's really water soluble and incredibly easy to measure in blood. And so we just stick with it, because with all the challenges of measuring something in urine, we just decided that's what it is. GB3 is also a difficult assay. It's not easy. Plasma GB3 and Lyso-Gb3. That's why we've moved away. And it's also, we've got a really good biomarker, which, is easy to measure. So why use other things? I think that's just that. We've just moved on. And as Jerry said, 20 years ago, we didn't have it. So many of our patients' baseline is GB3, not Lyso. Yeah.
And do you find that you're able to make any type of comparisons between
No, we tried. No, we
Mhm.
couldn't. No.
Okay.
Yeah.
So save those old records, but they might not necessarily translate to the modern numbers and the modern
Yeah,
time.
maybe, I don't know. If you had enough sufficient samples, maybe we could do some kind of, predictive modeling and compare, what the GB3 and, but, we haven't done that. But that sounds like a great idea to do, because those samples are valuable, absolutely, and those results. I agree. Maybe there's a project there now, Cassie,
Yeah.
to look at. Yeah.
Does anyone else have any questions? Oh, here we go. Would
right.
plasma Lyso-Gb3 show up in female if Fabry in the lungs? There's not much info re Fabry lungs.
Yeah, that's a great question. I think it's really an under-recognized and less understood part of Fabry. But if you had enough disease burden, you might have an increase. But as I said to you, unfortunately, with females, it might be elevated a little, but it may not sufficiently be elevated. So I think the way to look at it is that if you had lung involvement, look at Lyso, but look at also other biomarkers as well, is what I would say. Yeah, but it's a really good question. And I had another question. Tamara had a question.
I'm on my phone, so it keeps when every time someone beeps in, I apologize. I wondered if it's okay to just jump back quickly to the females and the GB3 not being so clinically relevant. I'm wondering, for a female like myself who has cardiomyopathy, I have a defibrillator, and now the cardiac MRIs are not showing up because they're sort of like a glare. So they can no longer see the scarring area and make clinical determinations based on, is the scarring increasing or not? Then other than troponin and proBNP, is there any other biomarkers that we can look at to determine progression, like whether or not my enzyme replacement therapy is of any use at all for me?
Well, I think, so the first thing I would say is that stability is a good thing in Fabry. So if there's no change, or there is some change for the better, then that is a positive impact. Now, the fact that you've required an ICD, now that is something that I don't see getting better with a disease-modifying treatment. So if a patient has an arrhythmia, they need an ICD. I get this call all the time. I get somewhere from middle of nowhere, somebody will call and say, somebody's had symptomatic bradycardia or somebody's coming in AF, the Fabry, they talk about Fabry treatments. I said, no, does this patient need a cardioversion? Does this patient need pacing? Does this patient please get on and do that's the most important thing. So that's not going to change. But I think what Fabry treatments will do for you, Tamara, is not just for the cardiac involvement, but also I think for your other organs, the fact that you have already developed cardiac disease shows that you have a certain level of disease burden. And therefore, what we're trying to do is stabilize that and also prevent you from actually maybe developing significant other organ involvement. That would be my view, particularly looking at small vessel disease as well. We say that enzyme replacement therapy doesn't cross the blood-brain barrier, but to me, it's about protecting small vessels. And therefore, I think treatment does work, but we're not perhaps necessarily saying that it's going to prevent every single stroke, but at least you're going to try and impact on the small vessels.
Okay.
That's what I would say.
Thank you.
Yeah.
Thanks.
Yeah, I just had a question about, you mentioned in one of your earlier slides, the N215S cardiac variant and a correlation with Lyso-Gb3.
Yeah.
Could you expand on that a little bit more?
Yeah. So the late onset cardiac variant, previously, it was thought that Lyso-Gb3 is not going to be elevated, or it was not elevated. GB3, we didn't see a correlation. But we now know that even in patients with a late onset cardiac variant, your Lyso-Gb3 will be elevated, but it's about the cutoff is 2.7 nanograms per ml. So it's not going to be like the 67 I showed you for the classic males. It's not even going to go to 25 or 30, but it's probably going to be very similar to the females. So it'll be somewhere around the 2.7 to about 10 is what I normally see in late onset cardiac, very similar to the females with Fabry. Yeah.
Okay, so to make sure I understand that,
it's for diagnostics.
who...
It's not for treatment. It's not going to impact on treatment. But so if you had a patient with a cardiomyopathy and you haven't got your genetic result yet, but you see a Lyso-Gb3 which is about 2.7 or something low, then you can be sure that that patient has got Fabry disease, because somebody might say, well, it's not high enough, so is this really Fabry? And I would say if it's over 2.7, that is Fabry disease. That's how it's useful. It's not useful for looking at efficacy of treatments. Does that make sense?
Would you say that if you have somebody who has been genetically diagnosed with one of these cardiac variants, but does not yet show any clinical findings, an elevated GB3 or Lyso-Gb3 over 2.7, is that saying that they almost certainly will develop cardiac complications without intervention?
N215S. No, I completely get what you're saying. And so, yes, if you had a younger patient who's got absolutely no evidence, and I've got patients like that, who've got a slight increase in Lyso-Gb3, but have absolutely no cardiac involvement, no Fabry involvement, based on cardiac MRI, by the way. So they don't have any symptoms, they don't have any signs of cardiac disease. We would always offer treatment. Now, I'm not saying that's the right thing, but we would always offer for a male, because we know that patient is going to develop cardiomyopathy, but it might be in a decade, it might be in 20 years. I don't know the answer. It might be tomorrow. So we would offer it. But some of our patients don't want it. They say, they're going to university. They tell me, Uma, I'll come and see you every year. Tell me when I need it. Otherwise, I want to go traveling. I want to do this. So I just treat every patient as they come along, and we discuss it. Somebody wants to go and do a particular job that they don't want to actually be on a treatment until such time they've, trained or whatever, then we look very carefully. And we do say, the sooner you start your treatment as an adult, then we would advise that. But if you have no cardiac involvement, then why not? We can monitor you. And those patients I will monitor more closely. I'll probably do a cardiac MRI more frequently. Whereas if you started on treatment, I probably will do now a CMR or cardiac MRI only once every 2 or 3 years. I'm not going to do it every year because the progression is very slow. So there's no need for us to do it. So it's every patient, Jesse, is different. And we don't, we just discuss it with families, patients, and whatever they choose, we work with them. Yeah.
Thank you.
You're welcome.
And we have another question from Travis. Go ahead.
Hi, Travis.
Yeah, for people who are already on treatment and you're measuring Lyso-Gb3 to see the possibility of antibodies or the effectiveness of treatment, are there other biological events that could cause Lyso-Gb3 to temporarily go up and maybe not be that? I would think that a follow-up would be, let's take another blood sample and see if it's consistent and maybe take it from there. But can you expand on that a little bit?
That's a good question. We do not think of Lyso-Gb3 as an acute phase reactant. So we do have, for example, there is a disease called Gaucher disease, and there is a biomarker called chitotriosidase. Now, chitotriosidase will go up if you had an infection because it's an acute phase reactant. It increases with inflammation, infection. Now, with Fabry, we do have inflammation. But I don't think there is enough evidence for me to confidently say that other things are going to increase your Lyso-Gb3. It could only be you have antibodies or the disease is progressing. Because it's multisystemic, it's not one organ. So, your disease is progressing and therefore your treatments are not working. It doesn't necessarily have to be anti-drug antibodies. But it could just mean that. So I think those are the things I would say, but I can't think of any other reasons why it might go up. At least I'm not aware. Yeah.
All right. Great questions, everyone. So thank you so much for being with us and providing this explanation. And thank you, Casey, for being here and doing a good job with watching the questions and your introductions, and especially thank you everyone for being here with us. And we will, I'm not sure what date we're back again. June 8th is our next webinar. And as most of you already know, we have a webinar index that we publish, and it has 73 webinars at the moment. We've got a couple to add. So anytime you want to learn something or get a refresher, you can look at the list of webinars and choose a topic. And there are many, many, as we started out, there were the standard heart, cardiac webinars, kidney webinars, neurology, pain, females, and lungs, and so on. And now we've transitioned to these notable publications. And I think we have opportunities to continue learning, and I learn something every day. And I'm happy to be a 71-year-old male with classic disease and chugging along. So thank you all. Have a good night.